welcome to the ASCO Guidelines podcast, one of ASCO's podcasts, delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Lyudmila Bazhenova from University of California, San Diego Moores Cancer Center, lead author on Therapy for Stage 4 Non-Small Cell Lung Cancer with Driver Alterations, ASCO Living Guideline, version 2024.2. Thank you for being here, Dr. Bazhenova.
It is my pleasure.
Then before we discuss this guideline, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including Dr. Bazhenova, who has joined us on this episode today, are available online with the publication of the guideline update in the Journal of Clinical Oncology, which is linked in the show notes. So then to kick us off on the content here, Dr. Bazhenova, this living clinical practice guideline for systemic therapy for patients with stage 4 non-small cell lung cancer with driver alterations is being updated routinely as a living guideline. So what prompted the update to the recommendations in this latest version?
Living ASCO guidelines are developed to keep up with rapidly changing evidence which affect treatment of our patients with lung cancer. In this recently published guideline, we reviewed new evidence for patients with metastatic lung cancer harboring driver alterations. We reviewed evidence from 4 published studies, MARIPOSA, MARIPOSA 2, CheckMate 722, and Keynote 789 that resulted in updated guidelines.
Great. And then based off those 4 trials that you just mentioned, what are the updated recommendations for patients with stage 4 non-small cell lung cancer and an EGFR exon 19 deletion or exon 21 L858R substitution?
In the previous guideline, we detailed FLAURA2 study, which was presented and published in the past. In this guideline, we specifically highlighted a phase 3 MARIPOSA trial, which took patients with untreated advanced non-small cell lung cancer, which harbored classical EGFR mutations, such as EGFR deletion 19 and L858R. In this study, patients were randomly assigned to receive amivantamab plus lazertinib or osimertinib or lazertinib alone. And the study showed that the primary endpoint, which was progression-free survival, was longer with amivantamab plus lazertinib compared to osimertinib. And numerically, the progression-free survival was 23.7 months with lazertinib versus 16.6 months with osimertinib, which was statistically significant. The challenge that we have to face when discussing that option with our patients is increased toxicity with amivantamab and lazertinib combination. For example, grade 3 treatment adverse events were 75% with amivantamab and lazertinib and 43% with osimertinib. So this will require shared decision-making between our patients and ourselves. We also noticed in the guidelines that there was a subgroup analysis of that study showing that the patients with a higher disease burden, central nervous metastasis or brain metastasis, as well as disease which considered to be a higher risk, such as co-mutation, for example, P53 and liver metastasis, they might benefit from intensified therapy. However, another thing that we are highlighting in the guidelines that at this point, we do not know how is the intensification of therapy will change overall survival of our patients. So one needs to take into account increased toxicity with that combination.
So then, Dr. Bazhenova, in addition to those updates for first-line therapy, what are the updated recommendations for second-line therapy?
For patients who have progressive disease on osimertinib or other EGFR tyrosine kinase inhibitors, we also updated our guidelines highlighting MARIPOSA 2 study. In the MARIPOSA 2 study, patients were assigned to chemotherapy versus amivantamab plus lazertinib plus chemotherapy versus amivantamab plus chemotherapy. And both of the amivantamab arm showed superiority in progression-free survival compared to chemotherapy alone arm, and therefore this becomes an additional treatment options for our patients who develop resistance to osimertinib. In addition, we also updated the results which highlight the lack of efficacy of immunotherapy in the patients who progressed on osimertinib. There were two studies that we highlighted. One of them was a CheckMate 722, which randomly assigned patients with metastatic non-small cell lung cancer whose cancer has progressed on EGFR tyrosine kinase inhibitor to receive either chemotherapy or chemotherapy plus nivolumab, which is an immune checkpoint inhibitor. And the second study was Keynote 789, which had a very similar study design. Again, patients who progressed on EGFR TKI also were assigned to receive chemotherapy plus pembrolizumab or chemotherapy alone. And in both of those studies, there was no improvement in progression-free survival when adding immunotherapy to chemotherapy. So for all your patients who are progressing on EGFR tyrosine kinase inhibitors and you thinking if addition of immunotherapy is necessary, we now have two randomized phase 3 studies telling us that immunotherapy should not be used in addition to chemotherapy for patients who develop progression on osimertinib.
Understood. I appreciate you talking about the evidence that supports these latest recommendations from the expert panel. So then you've already touched on this a little bit in mentioning shared decision-making and discussing toxicity with these new therapies. But what should clinicians know as they implement these new recommendations? And how do these new recommendations fit into the previous recommendations made by the panel?
Our previous recommendations did not include a MARIPOSA trial, so did not include amivantamab and lazertinib. So in our current guidelines for patients with newly diagnosed treatment-naive EGFR classical mutations have three options. Number one is osimertinib. Number two is osimertinib plus chemotherapy based on a FLORA study that we highlighted in a prior version of the guidelines. And the third is amivantamab plus lazertinib. At this point, we do not have any randomized head-to-head studies of those combinations, with an exception of FLORA-2, which is osimertinib plus chemo versus osimertinib. And so the decisions will have to be made on a cross-trial comparison, taking into account patient wishes, if they would like to receive chemotherapy or amivantamab plus lazertinib, understanding that this combination will result in increased toxicity.
Absolutely. I appreciate you detailing those considerations. So then finally, what do these new options mean for patients with non-small cell lung cancer and an EGFR alteration?
As a patient, it is important to also be aware of what options we have and have a direct dialogue with the physician, with a treating physician, trying to understand what option will fit with each individual patient goals, life goals, as well as toxicity concerns.
Definitely. It's always great to have more options for patients, and it's also important to discuss all of those options with their clinician as well. So I want to thank you so much for your work on this update, and thank you for your time today, Dr. Bazhenova.
My pleasure.
And thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.asco.org/living-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, which is available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.